for getting up and coming to listen. Now, we spoke together and we're going to switch around the topics. I start with the IOL calculations, very down to earth, very practical, and then we do the multifocal IOL part. So, when we do cataract surgery, it's crucial to get the correct IOL into the eye, because our patients are expecting more and more. And I'm sure it's the same in Europe and in the Middle East. Now, when we have all those formulas, we get bashed around the head with all the constants, which is the axial length we can't do without the keratometry, the ACD, the white to white, the lens thickness, the central corneal thickness, anything goes, basically. The old-fashioned way to do this was to do a manual javal. Do you still have a javal to measure keratometry? You do everything automated. Okay, so, well, in Europe somehow we're very conservative. We still have the javal, but we don't actually use it to do the biometry. And we know that every difference of half a diopter in the corneal plane in the keratometry is half a diopter in the spectacle plane. It's 1-on-1, okay? Now, if we have a difference in the A constant, 1 in the A constant is 0.8 in the final refraction. So that's when you look at your biometry and you see you're taking a lens that's 20.0. Thank you. Otherwise you can't hear me? I see.
No, nobody heard. This was
okay. So it's difficult to talk with my hands like that, but I manage. Then, so for example, if you look at the biometry, what you see is that every half diopter in your IOL power is 0.4 in the final refraction. That's when you have to calculate, you got the wrong biometry, you want to calculate on your own. Now, if you do have a scar, then you have to have a very good look at what you're going to take as a cane. Ultrasound biometry used to be the standard, and we still use it in very difficult eyes. And otherwise, we use optical interference. And the A scan, the ultrasound biometry, is like 54% of our mistakes because we press on the eye or we don't touch it enough, and then we get funny results. The thing is that when using the ultrasound, you do the 10 megahertz probe on the eye, and we get a resolution that's smaller than we need. It can discern up to 0.03 millimeters. When we use the optical coherence like the LensStar or the IOL Master, we can measure up to 0.00009.5 millimeters. So this is a factor 8 more accurate. And this accuracy translates directly into better IOL powers for our patients. Now, when using biometry with the ultrasound, we also have to take into account that every part of the eye will have a different transmission of the sound. So if we have the cornea, it has a different speed. If we have the AC, it has a different speed. If we have a normal lens, it will have a different speed. And like this, it's always a mesh of all those different speeds. We're making a mediation of all those ultrasound speeds, and that's why it's inaccurate, or relatively inaccurate. When you have the applanation biometry, you can see that the initial spike is the tip and the cornea. The B is the anterior lens capsule, the posterior lens capsule, and then we need a very nice spike of the retina. Now, when we do contact, doesn't matter how good we think we are, we will always be compressing the eye, exactly. And that's why we get 0.14 to 0.33 millimeters of mistake. We make the eye shorter, meaning that we will overcorrect, okay? Every millimeter of error in the axial length is 2.5 diopters in the final refraction. So the mean compression that we do ends up with the patient being 0.75 overcorrected. The spikes need to be exact. If the spikes aren't exact, you don't get the axial length, but you're off target, and you may get a completely different IOL that you're going. And it's very much operator dependent. Now, immersion biometry was invented exactly to circumvent the compression. So you make a chamber, you put in the gel, and then you put on the biometer. But again, the alignment is quite difficult, because if you're in this pocket of gel, who says that you're perpendicular to the macula? In any case, the spikes are a little bit different, because first you get the immersion, then you get the cornea, that's the B, and then afterwards the lens, and here the spike of the retina. Still, ultrasound biometry is very useful in difficult eyes. So the immersion technique eliminates the compression because there's no contact with the eye. What you can see here is the velocities, like I said, the velocity of the sound going through the different tissues or different lenses. On the right side, you can see in the phakic eye, the aphakic eye. And all these differences, we're summating them. We're making an average of this, and that's why we're being inaccurate. You can even see that two different silicone lenses may have different speeds of transmitting the ultrasound. Now, also the probe, the 10 megahertz probe, it's quite big. It's bigger than a finger. So we're trying to scan a very small area, which is the fovea. And the fovea has its shoulders. And the shoulders are a little bit thicker. So this is a second source of error from the ultrasound. And this is why you should actually not want to use the ultrasound unless you have no other choice. Okay? And the axis probe. If we're off axis, we'll have a shorter eye than we think. And we need to really see the orbital fat. We need to see those nice last spikes to make sure that we're in the right position. And they should be as tall as possible. In myopia, we have another problem, and that's the staphylomata. If we have a staphyloma in the back of the eye, very long eyes, we never exactly know where the macula is. So this is a real problem, and this is a problem that still remains. With any type of biometry, highly myopic eyes, above 30 millimeters, they're actually nearly impossible to measure. Then we get the inaccurate spikes and inaccurate measurements. So all along the way, we're only making mistakes. It makes us wonder why do we get good results at all, but we do. Now, the non-contact optical device, it works in partial coherence interferometry. So the IOL master uses a beam that's going in, and that's being split and then measured, and the lens star does a direct measurement. It's a technical difference. Both of them are very accurate, and the consistency is below 0.02 millimeters. It's a 10 or 8-fold improvement on the ultrasound. This is when I want to remind myself how it works. So we see the light going in, there is a interference being caused, and this is caught on the mirrors, and then the difference in the length wave, that will give you the length of the eye. The difference between the IOL master and the lens star. What I did is I just took the instructions for use of both machines. Okay, so the K reading of the IOL master is on 6 points. The lens star has many, many more points, so it's a little bit more accurate in giving you a good K reading. The ACD in the IOL master is from the epithelium, so thickened corneas will give you a different calculation. The lens star measures this from the endothelium. Otherwise, they both measure the white to white. The IOL master does not measure the pupil diameter. For the Thomas Olson formula, you want the pupil diameter. Then, the central corneal thickness is being measured by the lens star, not by the IOL master. The lens thickness, which we need for the Barrett's formula, and the axial length, of course. Okay? Then, So we have the IOL master that puts in the light and it's being split, and one beam reflects off the cornea, the other of the retinal pigment epithelium, and that's how we get a measurement. And it has an internal algorithm that coordinates it with ultrasound so that it will not be very different. The lens star also does optical biometry, a little bit of different light length. It's 820 superluminant diode, and then it has different LEDs for the different measurements, so the K is being done with a different LED. In terms of accuracy, well, the A scan we said is 0.10 to 0.12 between each measurement. The optical biometry is a factor 8 more accurate. So we're getting better results, are we? When do we have a good measurement? So we need a signal to be twice as large as the noise that's around it. We need a really nice tip of the graph. And this is both for ultrasound and for the optical biometry. And we want a secondary top. I'll show it in a few seconds. And you want to have 4 from 20 very good measurements. So you make a measurement and you skip the ones that are not good. And this we always compare to the Chrysler building. You want a you want a top and you want a secondary top. That's how it looks like. Okay. So in both machines the keratometry is integrated, and the thing is that the IOL master, I don't know if you do it yourself or your technician does it, but your patient has to fixate. And you have to see that the same keratometry that you get is still there in the screen when you press on the button to do the IOL, to do the axial length. Because if you get the keratometry and the patient loses fixation for a moment and then you press on the button to do the axial length, you may get a different length that you should have gotten. And this is a source of mistakes. You have to be really very concentrated on how you do this, okay? Now, the ACD is needed in some of the formula. The Holiday 2 uses this, and the Hygest does this. Why do they do this? It's actually, it's a substitute for the effective lens position. We can't say where the posterior capsule will be after the surgery, but we can say where it is before surgery. So from this, we can extrapolate. Now, the beam will do this, and will show us the anterior capsule. So again, A-scan versus biometry, non-contact, a slit beam. The A-scan has a limited resolution. The higher resolution comes with the optical biometry. We're making incorrect assumptions about the ultrasound beam. And in the optical biometry, it's independent of this. I will not trip on it. Thank you. I'll take care. Thank you. Then, the measurement in the optical biometry, however, is really dependent on a correct focus of the beam. So your machine has to be well calibrated. If it's not, you get a systematic error. So what did ultrasound biometry and optical biometry do for us? This is what we do with the ultrasound biometry. We shoot and we hope to get into the center of the target every time and again. But we have a scatter because of the different problems. The IOL master and the lens star, what it did is we get very accurate biometry. We get very accurate results, but we may be a little bit off target. And every time a little bit off to the same side. And then after you have a set of your own eyes that you did surgery on, then you can personalize them. The only thing that we're doing with personalization is that we bring the cluster on target. That's what we're doing, okay? That's our goal in getting better results. So I took this, do you know the site drhill.com? Well, he has a very big site on IOL calculations, on on how to do the biometry, how to get your own results better, how to do a checkup of astigmatism, your own induced astigmatism. I took this from there. And what he did is he put all the formulas in one place. And then he says, if you have a normal eye, and in his definition, a normal eye is 22.5 until 24 millimeters, and you have a normal K reading between 42 and 45, it's a quite narrow definition. You can use any formula you'd like, you will get good results. The moment the eye is shorter, like here, you will need to adjust. Now, for the moderately short eyes, the Hoffer Q works very well in my hands, in any case. And the newer formulas, which is the Olsen, the Barrett, and the RBF, I'll be talking about that in a few minutes, will have better results. In the longer eyes, you may need to take the newer calculations, and still long eyes are very difficult. So, the IOL constants, they're specific to the IOL. They're specific to the type of biometry. You will not use the same A constant for ultrasound biometry for one lens and put it into the IOL master, or for the lens star for that matter, okay? So it's specific to the machine and the lens that you're using. And if you really are the best of the class, you optimize it for yourself, okay? I don't know many surgeons who do it. We're talking about it, we're talking a lot, but in my immediate surroundings, I think I'm the only cataract surgeon who has optimized constants. So you really have to be very, very straightforward with what you think is important, okay? Now, we want a one-side. What's good about the optical biometry? They don't have to lie down or to sit up, or we don't have to move them around. They just sit behind the chair, sit behind the machine. We don't need to anesthetize, so we don't do anything about the corneal epithelium. You know, if you put on a lot of oxybupivacaine drops, will ruin the corneal epithelium. So this is very easy. It's non-contact, so we will not injure the eye, and we will not transmit infection. That's very important. And it's very quick. It measures aphakic eyes, it measures pseudophakic eyes, and also silicone-filled eyes. The disadvantages are dense nuclear cataracts. I think you may have quite a lot of these here in the desert. I think people come with quite hard, I call them cataracts, so I guess you have more experience in those than I have. And people with corneal scars, it's a problem because it gives an irregular cornea, so it gives us an irregular result. Vitreous hemorrhage because it gives a peak, and the peak is off the site where we need it to be. And we need software updates because we're advancing all the time. So the people who write the formulas write new algorithms that get down into the software, and we need the people to get us the new software. And we need cooperative patients, patients who can't sit up or who can't fixate or are otherwise debilitated. They can't do this, okay? So the A scan is for the uncooperative patients, babies, for example. So under anesthesia, we'll do it for children or in trauma. And for very dense cataracts and vitreous hemorrhages, we still use the A scan. So don't throw away the machine when you get a new one. Just keep both of them. And think of people with latent nystagmus, you know. The eye will go, they can't fixate. You can still measure them with a correction in, not a contact lens, but with the glasses it will go through. Okay? Now, I put a lot of formulas here, and I'll go through it fast because it's boring and we're not going to use it in daily life. So the SRK is a formula that was invented by Sanders, Retzlaff, and Kraft. And what they did is they took about 1,800 eyes and they measured the eyes and they made a scatter plot, and they came up with the idea that the A constant would be 90% of the K plus 2.5 times the axial length, and then you get more or less the one that you need. I put an example here. For example, your A constant is 119 for a lens, and you have an eye that has a K reading of an average of 44.5. So you take 90% of this, So you get to the 40, then you take the 2.5 times the 23, that's the axial length, millimeters, that's 57.5. So you deduct this part and this part from the 119, you get a lens of 21.5. Sounds familiar, right? So this is offhand. If you don't have a calculator in the room, you can on the top of your head just do this. It's fairly effective for normal eyes. So this has been working for us from the 70s to the 80s. We haven't been using anything else. A lot of people even use it in the 90s. But it doesn't take into account the ACD, the anterior chamber depth. So it's not telling us where the effective lens position is. Then they came up with a second one. What's the second one? They were thinking, hey, we're off target with the very small eyes and the very large eyes. So what did they do? They told you, well, if the eye is short, just add 3 diopters in your lens, okay? And if the eye is a little bit short, we'll add a little bit more. And if the eye is a little bit less short, we'll add a little bit, but less. So it's all a little bit feeling where the weather comes from, okay? And when the eye is very long, then you will just not change it. You will just leave it for that. Okay, so this was the SRK2. Basically what they did intuitively was to adjust for the effective lens position. And because in the hyperopic eye we have a very small eye, the nodal point will be more sensitive. So if the lens will be more backwards, they'll get more of a plus post-operatively. And this is what usually happens, right? They have big lenses, they have a small eye. We put in a very narrow, thin lens, and it will bend backwards, and that's why they got plus effects. So yes, you have to put in 3 diopters more to correct for that. Now, the SRKT was invented in 1990, and what they did is they put their whole plot onto a regression formula. It was very easy because computers were just coming out then, and they could use software that they bought, and that's the timing because of our toys, you know, the computers and stuff. So they corrected for a lot of things and got better results. Now Hoffer Q is another formula, and Hoffer is still living, right? And he's still writing a lot of articles about biometry. There are a lot of new formulas out there. There's a big discussion going on which is the best, you know. And then what he said is you should not only take into account all the things that SRK said to take, but he says you need a personalized ACD. Personalized ACD, I don't know anyone who has this. But what you have is the Hoffer Q formula gives you an ACD that's correct for a particular lens, which works for most of us doctors, okay? And if you put that in, your accuracy will increase, especially for normal and short eyes. It doesn't work well in long eyes, okay? It's worthwhile putting it into your data. Then came Huygens. Huygens is a very, very pleasant, nice man, but he is too smart. No, really, because these are his formula. I tried to look at this, and the only thing I do is I just put it in a calculator. That works fine for me. Then came Olsen, and what he said is you should include the post-operative ACD. Why the post-operative ACD? Because we know that the lens thickness is important. We need to know where the posterior capsule is after surgery. So this is his way of approximating this, okay? He also says that age is important because of corneal asphericity. Now, the corneal asphericity, I'm not so sure it increases with age, but we know that the spherical aberrations from the lens in the eye, they change, and we know that the spherical aberrations increase when your pupil is dilated. So he also takes pupil size into account when calculating. I borrowed these from one of his articles, and what he showed is that when you do the SRK1, you have a wider spread of your results. When you use his older formula, the yellow one, you also get a quite wide spread. When you use his optical formula which takes into account the pupil diameter, which takes into account the ACD, you'll get a much nicer spread or non-spread of your results. And then he also showed that depending on how much errors you have in measuring the ACD, how much post-operative error you will have, depending on the axial length. So the shorter the eye is, the bigger the change in the ACD will be, the bigger your error will be. Okay, so in longer eyes we have less errors based on ACD than in longer eyes. It only follows from the biology of the eye. Then Barrett from Australia, he wrote a theoretical formula, and he went from a totally different point of view. All the formula that I mentioned until now are thin lens formulas. And he said, I'm going to make a thick lens formula. He's a very smart man. I'm not that good in physics, so I can't really explain this. But again, the ACD is related to your result. And he said that there's a relationship between the A constant of the lens and the lens factor. And actually what he's trying to predict is also the post-operative ACD. If you look at the literature, you will see that the ACD will increase in depth by a mean of 1.47 millimeters. This is an article from Turkey from about 30 years ago. So we know that it gets deeper. And we know more or less how much, but we don't know how much in every eye. Now, this is Warren Hill. He's a very famous American cataract surgeon, and he has this website, and he is really the guru, I think, of lens calculations. And now he has come up with a different thing. He teamed up with engineers, and they decided they're going after big data. We're measuring lots of data all over the globe, and he has used in his new calculator the data of 230,000 eyes that were already operated upon. And from this data, he has an algorithm, so you put in data, you use it to make your next calculation based on what you got in the previous, exactly. And this you can improve all the time, so you need more data to come in. So for the normal eyes, he has enough data. For the eyes that are more rare, that are beyond the 2 standard deviations of what we have in our populations all over the globe, this is still not completely okay. So for diopters under 6, I think, and over 30, his formula may be off. So that's what when he says respect the boundaries, respect that you need to have the input that goes together with the data that he already has. And he's still gathering data, but he's being picky and choosy. So the data he uses from people he knows that keep their data, from people who are operating and not, I did a wonderful cataract surgery, I'm a very good surgeon. No, but from those people say, well, I'm not so sure, I want to see what I got. From these people he takes the answers, okay? So this is what a calculator looks like. You can Google Hill RBF, and then you get onto the site of the calculator. And you can put in the data, and it will give you a printout. The only thing is that this calculator is not yet incorporated into our IOL masters and lens stars. So this is more work for the cataract surgeon, and it has room for mistakes. We can do typing errors. So this is the main downside is the time and the typing errors that we will produce when using this. I use this because I use a multi-formula approach. So what do you need as a clinician? You need an IOL strategy that you do every time and again. You have to decide, when do I do topography? And this is all based on how much time you have, how much people to help you have, and if your system allows you to do as much as you would like to. For example, I work in 2 places. I work in an academic hospital, which is a very swamped place. We see lots of very difficult patients, and we will not do a topography in every patient unless we think there is a good indication. But then in my private practice, I'm the boss. We do topography on everyone. I will not do any IOL calculation without seeing a topography, because for me it's an integral part of making a decision what kind of lens I put in. Okay? Now, the surgeon's factor. This is a very nice discussion because basically we were all made the same. And the surgeon factor, we're not better or worse surgeons. We will not affect the effective lens position because the eyes will react the same. So the difference will be in how we measure. Is our measuring lane the same? Do we put in the same lens? Did we have a look at our own results? It's worth doing it because you're optimizing for the systematic error that's in your own clinical practice, okay? But if you don't, you will still have good results, but with a systematic error, a little bit off to one side or the other every time and again. Yeah. Surgically induced astigmatism is very important because if we're using even small incision surgery, we always induce a little bit. And if you notice, you only need 60 eyes, and there is a calculator also on the Dr. Hill site. You can calculate it for yourself. You can incorporate it into your own thing. And then you know what you're doing. So if you're not using toric lenses, you can decide I'm going on a steep axis, or I'll use relaxing incisions. With very little means, you can get a lot of good results if you want to. And if you have the possibility of using toric lenses, well, that's the nicest, of course. Again, I took this from Olsen, and this is what he says with optimization, and it's the same as the picture with the arrows. So if you have your own set, that's the red set, and you're going to optimize it, you'll just narrow it down. You'll have the same Gaussian distribution of your results, but it will be more on target. So it's worth doing, okay? Now, how to read the biometry. I'm going back to the basics, but reading the patient's name and date of birth, it's not funny. It's really very, very important, okay? Then this year, nearly put in the wrong lens. I had a patient with a very rare name, and for some reason, my optometrist didn't check the date of birth. I had 2 patients with the same name. I nearly made a mistake. But because of our checkout procedures, our timeout procedures, the patient had to give me his date of birth. And I looked at the biometry and said, this is not the same man. And I could prevent a mistake. So please check it and check it again in surgery. Okay? Then check symmetry between the eyes. Eyes should be symmetric unless people really have a big anisometropia, and then you'll know. It will read out in the axial length. You will see it in the axial length. Okay? And then, depending on your means, depending on your time, depending on the type of the practice that you run, you decide when to do a topography. You can say, everyone who has a cylinder higher than 2, I'll do a topography on. You know that in the population, 20 to 30% of people have a cylinder bigger than 1.25, but less than 1% have a cylinder bigger than 2. So here you have to decide what kind of error are you willing to incalculate into your practice? What's your cutoff? And I told you, in one practice my cutoff is much different from the other practice. And it's all regulated by whoever is our boss, okay? Then, if the anterior chamber depth is very, very shallow, you may be in for a hyperopic surprise because the lens will be so thick, you will get such a deepening of the anterior chamber that you will get a hyperopic surprise incalculated into what you do. Now, the prediction error, according to Olsen, a little bit more than a third comes from the axial length measurement. About 1/5 comes from the keratometry, and nearly 42% is from predicting the ACD. So the effective lens position is important. Again, we have checklists, and you can just print them out from online. This is for the lens star, this is for the IOL master. I don't know anyone who checks this off for every single patient on paper, but in your mind you should be doing it, okay? Now, I brought a couple of patient examples. This is a lady that I've been treating 4 generations of her family. She came with a cataract, and then she was measured. And the measurement shows us that she has a cylinder of 2.37 diopters. I don't know if you can see it. In the right eye, here, it's 2.37, it says, and here it's 0.59. That's odd, because she didn't have it in her glasses, and it surprised me. So I didn't buy this. I went to my technician and told her, what happened here? So this lady, she was very, very small. And my technician didn't notice that she was sitting like this with her chin in the chin strap. So she couldn't sit straight in front of the optical biometer. So we brought a cushion, we put her on the chair, we held her nicely, and all of a sudden her cylinder decreased to 1.54. This is really stupid. This should not happen, but it happens. So you have to be aware that along the way everyone has to take care, has to be attentive. And now this I could solve with relaxing incisions. I got a good result in her. Had I put in a toric IOL, I would have overcorrected. I would have caused her to pay when there was no need to. You know, it would have been an endless story. So this was very good. So be attentive. Usually the mistakes we make are not so smart. So you have to be really, I'm sorry, it's not very visible, but I'll talk you through it. So this is one of my nurses. And she heard I do very nice multifocal IOLs. Now, doing surgery on nurses is always a little bit scary because, you know, they know how to catch you when they need to. Mm-hmm. Now, this is her right eye after she was wearing contact lenses. And what we got is, you see, I do the multi-formula. So this is the Oculentis, this is the Acrisoft Toric, the Restore, the regular Acrisoft lens. And I got different results, 14, 14.5, 14.5. And I wasn't very happy because the keratometry was a little bit high. So I told her, you just take out your contact lenses, walk around with glasses. Don't worry, I won't look at you. And then we measured again. And we got down to a measurement of 14 on all formulas, except for the lentis. The lentis is a funny lens. So in the end, instead of putting in a 14.5, which would have made her hyperopic by 0.4, I put in a 14, just because I was on top of it. I didn't want to have a wrong thing. She had a vision of 1.5 afterwards in both eyes. Yeah, now she's very happy, and my life is good. So this is very important, to be on top of it. Don't be lenient. You can't afford to, because otherwise you will have to do a touch-up. If the patient can afford it, it's fine. Or if the doctor has a laser, it's fine. But if you don't, it's costly. And just because of not having any patience, you know, it's a pity. Now this man was a 38-year myop, and he had an ICL put in by someone else. After that, he's a myop, so they still get retinal detachments. He had a vitrectomy, and after the vitrectomy, with the ICL in place, he got a cataract and needed to go out. This patient was young, and he said, oh, I want you to take out the cataract and put in a multifocal IOL. Now, we don't make our lives ourselves. I don't need to tell you, you know, it's not in our hands. So we started measuring him. Here you have to take my word for it, it's a 3.19, and here it's a 298. Because of the ICL, the anterior chamber depth is different. Exactly, so you may get a hyperopic result if you go for that. I took out the lens, and I also told him, listen, you know, I will be needing such a lens for you, a 3 diopter lens or 3.5 diopter, 4.5 diopter lens. They don't really exist in multifocal IOLs. It's not completely true what I'm saying. Size goes in multifocal onto 3 diopters. Alcon starts at 6. I think the difference means a question of liability. If you start at 6, you're being smarter because your results are better. So I told him, you know what? I'm not going to do a multifocal IOL on you. I'm going for a plain monofocal IOL. If you'll be happy, it's okay. If not, we can always put in an add-on. I think you must be a little bit crazy to get surgery for your ICL. then get a vitrectomy, then get your ICL explanted, then get your cataract surgery done, and then do an elective add-on multifocal IOL. I didn't tell the patient that that's what I thought, but he didn't go for the last one. So I was quite happy with him. I guess I convinced him. Okay? So the predictability was a problem, and the retina was a problem. It's the same patient. In the end, we did it. Now, this patient was referred to me, very strange. He got a result that was not called for. They wanted to put in a lens to get him to -2.5, and he got a 3.35. Now, why did this happen? Anyone wants to have a go at this? They put in a power, yes?
Was he post-LASIK, this guy?
No, not post-LASIK. No, a pristine eye. He just came with the cataract. I'll help you. No previous surgeries. There's something missing on the scan. The ACD. They were using a very old formula. They didn't have the ACD, so they were using an old formula on an abnormal eye. The axial length is 24/45, but his K readings are 48. So there's something fishy here, okay? This patient probably had the hassasiyah. I think he was allergic, and I'll show you why in a second. So the ACD is missing. This patient had a keratoconus. So it's not enough to look at the biometry and just, pick the lens. You have to pick your brain. You have to look at the data, okay? It's very important. Now, this man wants a refractive lens exchange. And here I'm having difficulties because it's a quite normal eye, 24, 21 millimeters, and he has a small cylinder, but his cornea is quite flat. It's 39.7, 40.5. This is a flat cornea. It's under 42. And this will give you an odd result. And that's why I put a sign through the SRKT. I'm not going to do that. And I went to the Hofer Q because of the flat corneas, because it's relatively short because of the cornea. And that's how come this is his preoperative. He was a hyperop with a very good vision. Logmar is usually what he is. His axial length was 24 actually. So the axial length was normal, but the keratometry was abnormal. It was flat. So be aware that you need to be aware whether the posterior segment and the anterior segment fit together. If they do not fit together, you should look further for other formulae. Okay? So, post-operatively, the result that I got is that we saw a 1.0 decimal without correction, and with a very small correction, plano -1/2 on 120 degrees, we saw 125. That's the logmar, -0.1. Okay? And now this is the part that usually you get a result of 1.0. Why should you check the refraction, right? Because you're right on. But young people can see more than 1.0. And that's why you need to refract in order to be aware of your own results. That's the only way to make the extra step to become better. The calculation exceptions are previous refractive surgery, previous PKP, silicone in the vitreous cavity, and then we need different approaches, but this is beyond the scope today, so I won't go into this. Again, sometimes we do surgery and something happens to the bag, and then we need to put the lens into the sulcus. Also for this you need to correct because the lens is going forward. If the lens is going forward, you will have a more myopic result. So if you have a short eye, which means you have a high diopter lens, then you need to change the lens that you want to put in to a lower lens, okay? I put in an example. You're taking a lens of 29 and the eye is very short, so you change it by 1.5, you go to 27.5. And if it's a slightly less shorter eye, you'll change it by 1 diopter. And if it's a myopic eye, you will change it only by half a diopter. And if it's a highly myopic eye, don't change it because it won't have a big effect. Okay? So the shorter the eye is, the higher your correction should be. And there is no calculator for this. This is common sense, think and do. Okay? Now this is a picture that I made of the effective lens position. So if it goes back, you get a hyperopic result. If the lens goes forward, you get a myopic result, okay? Depending on the size of the eye, the effect is bigger. Shorter eyes, the effect of the lens position is much bigger than in a short eye, in a long eye. Now, a form of frusta keratoconus is a pitfall. I showed you in the biometry with the patient where they missed it because they missed a K of the 48. You need to prevent it in your standard operating procedures, your SOP. Again, you have to decide in your clinic when you go for that, okay? Toric lenses, I usually go for a toric correction when the diopter with the rule is 1 diopter and against the rule 0.75. But I have a special practice. I do 90% premium IOLs. But if you have a regular practice, a regular cataract practice, still you can do a lot about it with relaxing incisions and other things, okay? The calculators I showed you, these are the websites. Make a photograph of this if you want to go and check it, okay? Now usually what I do is in difficult eyes, I do all calculations of my IOL master. I go to Barrett, I go to drhill.com and I do this. I use the Huygens constants from the ULib. So there's an extra thing that you can do. So the technology of what we do is very important, but to know how to use it is also very important. Okay? Thank you. So this was the first talk. Do you have any questions? No, it was so clear. Yes? Sure. Yes, yes. A regression formula means that you have a population that you put on a graph, and then with software, which is, you have the software in Excel, you make a regression line through it. And the regression line has a slope, which is called R, and there's a factor coming out of that. And this you put into the formula, and for every point on the graph, you will a priori use the line, the R, exactly, instead of just taking the data from that point. Now, the theoretical formula doesn't use any data. It just decides that we're taking the axial length, we're taking the pupil diameter, and there is a formula which does not take into account live data of patients. Okay? Any more questions? Please.
If the patient came to my clinic for cataract surgery, both eyes,
Yes.
For example, 2012, and I did biometry both eyes. I have the calculation for the both. I did surgery for one eye with the same calculation. After 4 years, 2016, he came to me again. When I repeated the calculation for the other eye, there was a difference. Should I follow the previous one or the new one?
It's a very good question. Yes. Did you use? Very right. Say it out loud. Did you use the same machine?
Yeah, same.
The same
I have
machine.
the same machine.
Okay. And now, what was different? Was it the ACD that was different? Was the anterior chamber depth shallower, or was the keratometry different?
Keratometry.
The keratometry.
Yeah.
I would do a topography. I would do a topography to see if there's something happening on the cornea. People may have an herpetic infection sometimes, or they may have a limbal problem which causes their astigmatism to change. So I would look further into the data where it comes from. In the hospital, we would use the old one because of money issues. In the other one, I'm not sure what we would do. We'd probably just put the patient through all the tests again and then decide what to do. Okay, so, and I also would take into calculation the result of the first eye. So you have the result of the first eye of your first measurement, you know how you came out. If your result was good, there's no reason to believe it wouldn't be good in your first measurement. I wouldn't just go for the second measurement. But that's a problem. More data give more yeah, more things to think about, okay? If the AC depth was different, if it's shallower, it's just an advance in cataract, and then it wouldn't be a big problem, okay? Sir?
If the cylinder is different on biometry and on topography, which one you use?
Yeah, that's a very big issue. I usually go for the cylinder on the IOL master because that's been my. The thing is that in your practice you need to have a standard operating procedure. You have to standardize how you work. So I look at the topography. I look that the difference isn't too big. If the difference is too big, I may repeat the measurements. I may put in a drop of cleanse. These are drops that disperse my bone when people use contact lenses. I take the drops and use it before I do the measurement. It disperses the meibomian secretions that are on the eye and will give a very nice reflection of the cornea. So I usually repeat and see if there really is something. And it's rare to have very different measurements. So either technically something must have gone wrong, or the patient's tear film is really horrible and you need to do something about it. Okay? Yeah. We'll have a 5 minutes break, right? And then I'll continue with the talk on multifocal IOL technology. I will be explaining how it works and how to choose your lenses if you're using it, okay? Thank you.
Excuse me?
Yes.
Should we monitor the machine yearly or after 3-4 years or according to the company?
Well, for every machine there is a calibration program. And depending on your practice, So, depending on your practice, you should calibrate your machine. So we calibrate weekly all our machines. There are practices that do it daily. I think that's too much. But you have a calibration thing, okay? Okay, so we're basically taking 5, right? Good.